we need is real-time monitoring of their fixation so that they are able to move their eyes around so that they can see. And the field equipment, the macular perimetry, can deal with that. And we want to be able to show a target and know we showed it where we wanted to show it, not where the patient happened to be looking at that particular point in time. Certainly most of our knowledge about macular perimetry, about fixation, about scotoma comes from the Rodenstock SLO, and a great deal of research has been done with these instruments. These are great instruments. They give us a great amount of information. But the reality of this is that they aren't readily available anymore. You have to, maybe if you're lucky, buy them on eBay, and they can't be maintained. They're running Windows 95. So we have a very useful tool, a tool that's given us a great deal of information, but not a platform that we truly can move forward with. The NIDEC MP1 microperimeter does allow real-time tracking, and they can compensate with that hardware in terms of the patient's eye movement. So we're able to get that quality of information that we need about the scotoma, and in addition, we can get the information we need about fixation. Where is fixation, and how good is fixation? The information about the quality of fixation can be mapped. So the blue dots are indicating fixation. The closer they are to the center, though the more tightly they are grouped together, the better one's fixation. And conversely, the more spread out, the poorer fixation. So what we get with the MP1 is perimetry, or patient response about what they see at a certain location. We have the image of the retina, fundus image, and then these two can be superimposed. That image registration is done either by the software in the machine itself, or it can be manually done at the end of the procedure by choosing a landmark on both the perimeter image and your photo image, and then they're simply superimposed. Okay, I'll show you a little bit of information about what we can get from this kind of clinical tool. Some of the patients have read the books, and they have just what the textbook says, a central scotoma right in the middle. And in fact, that's what we see here. This patient has a dense, moderately dense central scotoma, surrounded by seeing spots. Well, they may have a central scotoma, but a slightly different configuration. So now we have a vertically elongated scotoma, useful information, but we really are left with another question. Where's that patient fixing? So let's say they're fixing over here. That would give them a scotoma to the left. And as I'm going to go on to show you more, I'd predict that patient would have trouble with page navigation. When you want to drop down to the next line of print, if you've got a scotoma to the left, it's obscuring the beginning of the line, and you lose your place. Maybe they would be fixing over here, have a scotoma to their right. That kind of patient is misreading the ends of words. Or when something's $100, to their surprise, they were mistaken when they thought it was $10, and that second zero was buried in scotoma. Here we have a patient who we know where they're fixing. The little blue dots indicate probably foveal fixation, or very close to it. Quite good fixation. Those are pretty tight. And now they have a scotoma, quite a dense scotoma, over here to the left of fixation. But in terms of vision rehab, or reading rehabilitation, what we see here is a nice, well, maybe 6-7 degrees from their location of fixation to the edge of their scotoma. I'd predict that patient's going to have a pretty easy time to read. This may get in the way when they're trying to see faces. It may get in the way when they're trying to see a computer screen or TV, but likely for continuous print reading, they do quite well. So what we're getting here is the information we need about the scotoma and about fixation, and the fixation relative to that scotoma. Here's another patient with central fixation and a very dense scotoma. This, in fact, is in superior field. It's inferior anatomically, but superior field. Doesn't give much problem. Person would be able to likely read quite nicely. If we look here now, again, we're back to that same issue that I mentioned before. A dense scotoma, left of fixation. Very likely this patient's going to tell you, I can't find my place when I'm reading. I get started and I'm lost, and I'm looking again for where I should pick up my reading. So even though they might have quite good acuity, a patient with a paracentral scotoma can functionally be having a lot of trouble. We can take 3 patients, 5 patients, 10 patients, they're all 20/70. But doing perimetry to find the location of their scotomas can show us that those patients have a very different task of adjusting to their macular disease, despite the fact they may all have the same acuity. And this is a very interesting configuration now, and this is a schema of what we call foveal-sparing or ring scotomas. This morning in the retinal subspecialty group, Dr. Moak presented a series of AMD dry and wet patients in terms of their vision function characteristics. And I'm doing this by memory now, but I believe she reported that ring scotomas, which I'm going to show you now, she found in her series occurred in 30% of vision rehab patients who had dry AMD and 20%, 30% of the wets and 30 of the wets and 20 of the dries. It's not an uncommon situation for macular degeneration patients to have good acuity because they still have foveal vision and the ophthalmologist is happy, but a lot of trouble with function because they in fact have paracentral scotomas that border their center vision on 3, if not 4 sides. So what happens now when this patient wants to read? They're looking at a long word and they can't see the whole word. They can only see parts of that word. These are patients that walk in your office and tell you, I don't know what's going on. I'm able to read the newspaper, but I can't read the headlines. Why is that? The headlines don't fit in their central area of vision, whereas the newsprint does. These are folks that may come into your offices with acuities of 20/30, 20/40, and they're bitterly complaining. And unless you have ability with macular perimetry or some means to monitor where that fixation is and where that scotoma is, this is one that you can certainly miss. Okay, here's an example of a ring scotoma, and I'm going to show you this a little bit more detailed. Oops. So this patient has these red fill dots or spots that they see, okay? So this is a small central area of seeing retina, likely correlated with very good acuity. But we have these open squares all in this area. And this is a ring scotoma, a very extensive ring scotoma encircling a small seeing area. And then beyond that, as we go more peripheral, we now have these solid squares again. This is all seeing retina. So this is a very good example of a patient with macular degeneration who has good visual acuity, but when you dig a little deeper and find out where their scotoma is, you uncover this pattern of foveal sparing or ring scotoma. These are very undiagnosed and underappreciated, and certainly these are patients who can benefit a lot from vision rehabilitation. A couple of more examples of this. Oh, next question. I said, if you know where someone's scotoma is, you have to answer question number 2. What about fixation? So in the case of this patient, they were fixing in that central area. Makes great sense. That's close to fovea. But in addition, you probably can't perceive from far away, but there are many blue dots, fixations indication, all through here. I've marked some of them. So this patient has very poor fixation. They're having a lot of trouble keeping an image in that center, and they're scanning all around in their scotomatous area, trying to pull together some kind of a perception of what they're trying to look at. The rehabilitation that we do with this, this is a challenge for rehab, but it certainly can be something you can have success with. The first step is that the doctor and the patient both know what's going on, and there's why you need the perimetry. Once you have that information, intense lighting is very useful. It causes that relative scotoma area to be modified. Education about how to use this center area realistically, spot reading, small areas, and so on. You give this person a magnifier and make the image go from here to here, and they'll tell you this magnifier makes things worse. And these are patients who were, for a long time, not understood in vision rehabilitation because they were the complaining patients who didn't like the magnifiers. And now we understand why. The third part of rehab would be to teach the person how to use more peripheral retina and to have appropriate magnification so they can do it. So it's a staged rehab, that's done for these foveal-sparing scotomas, foveal-sparing